Welcome to the weekly morning resident lecture, and I want to welcome and present Dr. Vijani. So the topic today is benign and malignant tumors of the gallbladder. Important issue. It's not such a frequent disease, but I think we will concentrate today on gallbladder cancer. Okay?
Okay,
it's yours.
Thanks a lot. So good morning, everybody. Today I'm very happy to give you this talk about malignant benign tumors of the gallbladder cancer. I will start with malignant tumors. We'll go through epidemiology, clinical presentation, diagnosis, pathology, staging, treatment, and then prognosis. And then we go over to benign tumors, focusing mainly on gallbladder polyps and their management. So brief overview of gallbladder cancer. It's a disease which was first described in the 17th century, 1777, by Maximilian de Stola, an Austrian pathologist. It's considered rare, but it's still the most common and aggressive malignancy of the biliary tract, accounting 6th among the gastrointestinal cancers and almost 2% of all cancer deaths. Epidemiologically speaking, it has shown to have an important women predominance, being 2 to 6 times more frequent. It's a disease of the elderly, meaning that the average diagnosis is 72 years of age. It has a striking geographic and ethnic distribution, with a worldwide incidence of 2 per 100,000 individuals. It can go up to 35 per 100,000 in some nations of the world. Since it is very aggressive and usually diagnosed too late, the mortality rates follow the incidence. Overall, we can say that it's a disease which is decreasing in our Western world due to the rise of healthcare system, due to the rise of cholecystectomy. And so it's prevalently, as we can see in this picture, present in some nations of the world, particularly South America, India, Pakistan, Japan, and some ethnic groups like Native Americans. There are a lot of risk factors which play a role in gallbladder cancer: genetic variation, associated disease, environmental factors, lifestyle changes. However, they all share one common thing, which is an increased chronic inflammation, which leads to repeated tissue damage and proliferation, release of cytokines, and therefore an increased oncogenic transformation potential. So my first question is, what do you think is the most relevant risk factor of gallbladder cancer?
Gallstones.
Exactly. Gallstones disease are the most relevant factor of gallbladder cancer. In fact, gallstones that more than 3 centimeters have shown to have a 10 times higher risk of developing gallbladder cancer compared to gallstones less than 1 centimeter in size. Also, the gallstone composition may play a role. Population like South Americans with gallbladder cancer have usually gallstones with prevalently cholesterol type. Then personal gallbladder, which is this chronic inflammation of the gallbladder with calcification deposits, which appear bluish in the CT scan like a porcelain pot. PSC, chronic infection, for example, Salmonella, Helicobacter, carcinogenic exposure, metabolic syndrome, family history, and some anatomical malformation like the anomalous pancreaticobiliary duct junction, which is actually which increase the reflux of pancreatic juices into the gallbladder, promoting chronic inflammation and promoting this oncogenic transformation that we talked before. And also, last but not least, gallbladder polyps of more than 1 centimeter have shown to have a malignant potential. Again, there's actually a reason, we can say there is a reason why gallbladder cancer is so frequent in some regions of the world. As I take, for example, again, the Chile, Bolivia, and Ecuador, those are countries in which some infections are endemic. There is a lot of carcinogenic exposure, a lot of pollution, also India, Pakistan, and therefore those are increased risk the risk factor increase also the incidence of this pathology. So how does it present? Usually gallbladder cancer may present asymptomatic, and like every tumor, it may present with a typical tumor manifestation and presentation, meaning weight loss, fever, malaise. But still, according to the location or localization of the tumor, you may have different presentation. If the tumor invades the cystic duct and obstructs the cystic duct, it may present as an acute cholecystitis, giving pain, right upper quadrant pain or epigastric pain. If it occludes the common bile duct, it will result in jaundice. And I want to make you aware of obstruction because sometimes the tumor invades the duodenum, giving a cholecystoenteric fistula, which is maybe one of the first manifestations of very advanced gallbladder cancer. However, always keep in mind, 60 to 80% of this cancer of this diagnosis, this presentation is silent, and the findings are incidental finding after the pathologist explores the specimen he gets after the operation. Diagnosis: gallbladder cancer may be diagnosed preoperatively, intraoperatively, or postoperatively. However, we should always approach a patient with a thorough medical history, asking about risk factors, the one we saw before, and doing a physical examination, right upper quadrant pain and abdominal mass. Then blood tests may help, are not diagnostic for gallbladder cancer though, because tumor markers may be elevated, for example, also in other conditions, rheumatic conditions. They're not specific for this cancer. Liver function tests may be alterated if the cancer invades the liver, and so the function of the liver is disrupted. However, all gallbladder pathology should be approached with ultrasonography, where we can see actually intramural invasion of the cancer. If you suspect a malignant tumor, you should go for cross-sectional imaging. Computerized tomography, magnetic resonance may give you a hint of invasion of adjacent structures and may give you very important information. Last but not least, endoscopic ultrasound is very helpful to get some probes through biopsy. However, diagnosis is mostly not made preoperatively. So, as I said before, incidental findings is usually the most common way it is diagnosed, unfortunately. I want to outline the importance of PET-CT scan. PET-CT scan has been shown, compared to contrast CT scan, to have very, very good, I would say great sensitivity in sensing metastasis, distant tumors, and therefore PET-CT scan may very much influence the surgical and oncologic management of the patient, making a patient eligible for surgery or just for chemotherapy. Pathologically speaking, the tumor is 60% of it is mostly found in the fundus of the gallbladder, 30% in the body, and 10% in the neck. And from the histology point of view, the most prevalent, most common type of this cancer is the adenocarcinoma. I recall briefly the mucosa of the gallbladder is very similar to the intestinal mucosa with simple columnar epithelium, so the adenocarcinoma is very similar to the one in the gastric tract. A minority of this tumor is the squamous cell carcinoma, which is more rare but more aggressive, and then a very low minority may be endocrine tumors, outside carcinoma, and so forth. Keep always in mind why it is such aggressive and lethal tumor. It's actually, the answer is actually in the histology, in the pathology of the gallbladder itself. Gallbladder has just a mucosa, and after the mucosa, it's in direct contact with the adventitia, which contains blood vessels, nerves, and lymphatics, so the spreading is very fast once it invaded the adventitia. TNM staging system is the staging system used of choice, I would say, for this tumor. This one is now we have the newest edition is the 8th edition, which differs from the 7th edition through a couple of things. First of all, the T stage. So T0 is no evidence. T1, carcinoma in situ, is the tumor confined to the lamina propria or to the muscular layer. And in the T2 stage, they introduced two new concepts. So T2 is the tumor in the perimuscular connective tissue. T2 was subdivided in T2A according where the tumor is located. T2A is peritoneal location of the tumor, and T2B is the hepatic side of the tumor. That has shown to have a prognostic importance, being the hepatic side located tumor have a worser prognosis. T3 is cirrhosis and/or invasion of adjacent organ. T4 is vascular invasion or invasion of 2 or more extrahepatic organs. Going over to the end stage, also here there have been made some changes. Basically, they switched from a location-based assessment to a number-based assessment. The N0 still remain original lymph nodes, that's obvious, but N1 and 2 changed. So now it's important to know how many regional lymph nodes are involved. N1, 1 to 3 regional lymph nodes are involved. N2, 4 or more regional lymph nodes are involved. Previously, as you see in the picture, the location was more important. So N1 were cystic nodes involvement, then N2 retroportal nodes, and so on and so forth. But also this was changed because of the prognostic importance of the number of lymph nodes rather than localization. Distant metastasis, well, M0 is no distant metastasis, M1 is distant metastasis. Distant metastases are very pragmatic, are all those lymph nodes which are affected beyond the hepatoduodenal ligament, so periaortic, pericaval, superior mesenteric, or celiac artery nodes. The tumor has usually a direct hematogenic or lymphatic spreading, and when it metastasizes also to the liver, it usually metastasizes to segment 4B and 5. So treatment, very important. Just to give you some principles to apply to gallbladder cancer. So the only curative treatment is the R0 resection, and therefore resectability and staging are fundamental. Keep in mind PET-CT, as I told you before, and cross-sectional imaging may be of great help in this occasion. And generally speaking, what you can't resect, you can't operate. So chemotherapy is actually the treatment of choice for unresectable disease. Unresectable disease are considered liver and peritoneal metastasization, involvement of these extraregional lymph nodes, so lymph nodes beyond the hepatoduodenal ligament, malignant ascites or vascular invasion. However, we heard before in the introduction, it's a disease which is uncommon in the Western world. And so there is also, unfortunately, a lack of a proper prospective randomized trial. The studies which are available now are retrospective of little study groups, so there are no well-established principle to treat this pathology. Going through the stages, T1, so carcinoma in situ and gallbladder cancer confined to the lamina propria, a simple cholecystectomy has shown to have a great prognosis, so 80 to 100% survival to 5 years of rate. 2.1b, tumor in the muscularis, also very good survival, but here's a slight difference in the treatment. You should go for an extended cholecystectomy, which is in-block resection of the gallbladder with a 2 centimeters liver rim. Different story for T2A tumors. So T2A and T2B, the prognosis decreases steeply or dramatically, I would say. And you should go with a more aggressive treatment, an extended cholecystectomy and wedge resection of gallbladder bed, and segmentectomy for B5 if needed, plus lymphadenectomy of hepatoduodenal ligament. T3 to T4, story changes drastically. So you see survival rate very, very miserable. However, extensive resection to obtain negative margin should be the aim of the surgeon. But we have to be fair, it may end up in a pancreatic duodenectomy, right hepatectomy. But you have to say that you have to consider case by case when patient present with tumor in this stage. So it's a personal and individual decision that you have to talk with the patient and also if it's technically possible. T4, so actually any T's plus N2 or metastasization are termed as unresectable. Vascular invasion, extrahepatic organs invasion, as I said, make it difficult to operate. So the only thing you can do is address the patient to an oncologist to undergo adjuvant chemotherapy. Sometimes palliation with stenting and intestinal bypass may help, but it's still not curative because the disease is actually unresectable. Yes, oncologically speaking, there are actually first-line therapy is a combination. You have the choice between 3 drugs: fluoropyrimidine, gemcitabine, or platinum compounds. Second-line treatment has not standardized yet because of, again, lack of prospective randomized trial. But radiotherapy has shown to be marginally useful. However, you should encourage patients to enroll in clinical trials and to explore more possibilities. Briefly, again, prognosis, we talked about that already, but as you can see also from the graph, first stages, cancers in the early stages have a very, very good prognosis, up to 80 to 100%, whereas as soon as the cancer invades the adventitia, so blood vessels, nerves, and lymphatics, so it spreads, the prognosis decreases steeply. So far, so good. Now we'll talk about benign tumors. Benign tumors may be divided in epithelial origin because of this resemblance between intestinal epithelium and gallbladder epithelium. The adenoma has a similar biology to the adenoma of the intestinal tract. Mesenchymal tumors like leiomyoma, hemangioma, or lipoma may also be present, but are not that common. And tumor-like lesion like cholesterol polyps, which is not well understood, actually, the position of cholesterol in the gallbladder, or adenomyomatosis, which is the non-neoplastic growth of mucosa of the gallbladder, may also be present. You can also encounter them, and it is very important to know them. Usually when we talk about benign tumors, we talk about gallbladder polyps. What are gallbladder polyps? Well, an elevation of the mucosa into the lumen may be divided, that's very important, in pseudopolyp and true polyp. Pseudopolyp have no neoplastic potential, and pseudopolyp usually do not grow. Whereas true polyps, as I said, adenoma, adenocarcinoma, have a malignant potential. Only 5% of all polyps are considered true polyps. So briefly, talking about the adenoma, most common polyp, it's important to know this entity because it's male in the body, less than 2 centimeters in size, maybe solitary pedunculated or sessile, and the adenoma carcinoma transformation is possible, although not well understood. They have found a specimen with big adenomas, more than 1 centimeter, with malignant transformed cell in it. So when you approach an adenoma, which is greater than 1 centimeter in size, solitary or sessile mass, associated with risk factor like gallstone disease, age more than 50, or grow rapidly, it should raise our rate of suspicion because it may predict malignancy. As we've seen before, actually, when you approach gallbladder pathology, you should always start, let's say, with an ultrasonography, which is very important. In ultrasonography, you can distinguish between true polyps and pseudopolyps. Obviously, it's operator dependent, but you can say, generally speaking, that true polyps are hypoechoic, are immobile, maybe sessile or pedunculated, have no posterior acoustic shadow, and are vascularized, whereas pseudopolyps are clearly hyperechoic and have this particular pathognomonic comet tail sign. However, general rule, if you're not sure and you see a clear infiltrating or large mass, you should treat it as a cancer and therefore go for cross-sectional imaging like CT, MRI, PET-CT scan, as we said before. Those are the guidelines about the management of gallbladder polyps. It seems a lot, but I tried to summarize it very easily. You have to ask yourself 3 questions. So once you have excluded a pseudopolyp, you have to approach this management with 3 questions. The first question is the size. How big is the polyp? Is the polyp bigger than 1 centimeter? Yes. Then it may have malignant potential. The adenocarcinoma transformation, keep that in mind, should be possible, so you should advise the patient for cholecystectomy. Is the polyp less than 1 centimeter in size? Okay, it is. But still, does it provoke symptoms? If it provokes symptoms, there may be an underlying inflammatory pathology, and therefore risk factor for gallbladder cancer, therefore address the patient to cholecystectomy. Third question and last question for the management is, size is good, so less than 1 centimeter, no symptoms, but now you have to evaluate with the medical history, does the patient has risk factor? Risk factor, as we've seen before, age, ethnicity, PSC, so chronic inflammation condition, sessile morphology. If he has, and the gallbladder polyp is from a dimension which is considered borderline, between 6 and 9 millimeters, you should advise for cholecystectomy. If the polyp is less, so it's quite small, is about 5 to 6 millimeters, careful follow-ups of 6 months, then 1 year, then 2 years should be advised. If the patient has, on the other side, no risk factor, follow-up is enough. Again, 6 months, then 1 year, 2 years, 3 years. The most important thing, keeping in mind about follow-up, is that if during the follow-up, regardless of the periods of control, if the polyp increased by 2 millimeters or more, cholecystectomy is actually the preferred treatment because usually polyps which grow fast may predict malignancy. If the polyp reaches 1 centimeter, cholecystectomy should be advised. If the polyp disappears, you can discontinue follow-up and the patient is out of danger. It's again the overview of the gallbladder polyp management and the actual guidelines. Take-home message and conclusions of today's lectures. Malignant tumors are rare but very aggressive disease, so always keep that in mind when approaching gallbladder pathology. Although if it's not very, very common in the West, in Western countries, because it has an extensive geographic variance, it's important to know this cancer. Also, the associated risk factors, so chronic inflammation, gallstones, infections, or PSC. Surgery is the only curative treatment. So staging and resectability are fundamental, therefore TNM staging are predictive for outcome. It's an overall disease with poor prognosis, but if treated early, it may be, let's say, curated with a very good prognosis. Benign tumor are usually asymptomatic, may be divided in true or pseudopolyps. Pseudopolyps do not grow, so this is also important for the management. Adenocarcinoma sequence is possible, that's why we follow them up so closely. And the size, so more than 1 centimeter, symptoms, risk factor influence the management. Thank you for your attention.
Okay, very well done, Lorenzo. Very nice summary. I mean, he said everything except 2 things we have to perhaps discuss. There is one benign disease which can mimic gallbladder cancer, which we did not mention? Anybody knows? A benign condition which can mimic gallbladder cancer. And sometimes it's very difficult to assess this preoperatively and to have the right strategy. Meritzi. So sometimes Meritzi syndrome you could explain briefly what Meritzi is?
Is the extra biliary compression of the biliary tract, which causes pain and resembles.
Yes, and sometimes the stone can even erode into the bile duct, so that you have a mass where you don't know, is this a benign mass, is this a gallbladder cancer? So this is sometimes a difficult situation. Gallbladder cancer has a worse prognosis, as you said, and sometimes it's very uncomfortable to make the diagnosis during surgery. So because you don't know how much you have to exceed and to resect, then the best thing is to stop, wait for the diagnosis. It might be you have to complete extended cholecystectomy plus lymphadenectomy or even larger operations after you get the diagnosis back. Okay. Any questions?
Very nice overview. Thank you very much. I have 2 questions. If you have in the preoperative imaging suspected lymph node interaortocaval, which would be considered metastatic condition, would you still consider surgery if you think you could resect that R0? If it's unclear whether that would be a metastasis, or what would be your preferred choice of treatment? The second question would be, if you have a T2 situation, would you consider a different management in case of a peritoneal site versus the hepatic site?
I think peritoneal site I would not do. I would stick with the same, except, you would think if you have peritoneal site, you have a higher risk that you develop peritoneal carcinomatosis because the tumor is just exposed to the peritoneum. If it grows into the liver, it makes sense that you do extended cholecystectomy. It might be if I know it's on the peritoneal side, I go with extended 2 centimeter rim because I know it's not in the liver. But if I know it grows into the liver, it might be I go more for gallbladder bed resection, even for segmentectomy, just to get rid of the tumor, if we are within the T2 stage. But overall, I think the principle should be the same. And the first question is a good question because it's a distant metastasis. Question is, how convinced are you before surgery that this is a really malignant lymph node? If you have a biopsy proven interaorta, then I probably, with this aggressive disease, you should not go into surgery. You should give chemo and then you see what happens. But, sometimes we have a PET-CT positive lymph node, could be inflammation. So, but if you know it's an interaortocaval lymph node metastasis, it's a distant metastasis from a gallbladder cancer, you should not go into surgery for this. Yeah.
Thank you very much. If you do a cholecystectomy for inflammation, for example, and then you find a possible tumor, so how you have to proceed?
This is exactly what I mentioned. It's an uncomfortable situation. I think what I would suggest is, depends. If you have a big mass, then I don't know how you have to handle this. But let's say you have a T2 situation, you have a Schnellschnitt, a frozen section, and comes back, then probably I would stop. I would do the workup. I would complete the workup, and then I would go 1 week later for stage-dependent treatment. That means T2, extended cholecystectomy, lymphadenectomy. Also, I would go with a PET-CT to see if I have distant metastasis. Because if you have distant metastasis, it makes no sense to go for extended cholecystectomy. So that's would be my advice. And basically, this is also when we get patients out from outside hospitals. They come always with these situations, underwent cholecystectomy, came back in final histology. The 2 was a gallbladder cancer, and then we complete this here. So there's nothing wrong to stop and to wait and to complete the workup. Other questions? I think that's it. And thank you very much.
Thank you to you.
Lorenzo, very well done.